I think the answer to that is a purely empirical one, and I don't know the physiology of this, but I think everybody's experience is that if you give it on an empty stomach, you're much more likely to have trouble. And I always give it with food. I stress this. And a couple of things which I think are practical value. I give them a little white card telling them how much to take. And just like people who take anticoagulants, and they carry this card with them saying that they're on it and what dose they're taking. And I think probably we could persuade some drug company to put out this card and let the patient carry it so that they know exactly what they should take. And when they're at home, I ask them to put it on the wall by the breakfast table so they don't forget. I emphasize taking it with food and crushing it up. Arthur always emphasized this, crushing it up, and I think it's a very important point because it minimizes the side effects. Any drug, of course, can irritate the intestinal tract. It's not just that we should always give drugs with food, in my opinion, except in special circumstances.
But there are side effects with L-Dopa, which I think maybe we should hear something about.
The side effects are the bane of my existence at this point. In the outset, in our study, we divided our patients into the two groups quite arbitrarily at the age of 65. The younger group I think our youngest patient is 48 to 64, and the older group from 65 on up. We had no hesitation in starting any patient, no matter what his age, on L-Dopa, and no matter what the extent of his disease was. We found, as was already mentioned in the literature, that the older age group had a higher incidence of complications, while the younger age group seemed to do very well. Complications we run into most frequently in both age groups are nausea and vomiting, and we found, again, as David mentioned, empirically giving it with food and crushing the tablet or opening the capsule seemed to help a little bit. And we would have to often add anti-nauseants to it. In the older age group, constipation was a big problem, and for that, all we can do is give the usual laxatives, enemas, suppositories. Insomnia has been a problem in both age groups, surprisingly perhaps more of a problem in the younger people who are more active and require a little more sleep to be able to get through their day's work. We found here most of the usual bedtime hypnotics are fairly effective. We ran into severe complications such as hypotension and psychotic reactions very rarely in the young group. I think only about 2 of our patients. Both of them responded very well to lowering the dosage of the drug. In the older age group, though, we have run into these complications frequently, hypotension especially, and it is in this group that we have run into most of our treatment failures because we would have to lower the dosage of the drug to the point where it was almost not helping. And in many cases, in fact, we had to stop the drug in order to avoid some severe complications of hypotension. I think then you could predict as a group that the older people will have more complications and will require more conservative treatment. But of course, you can't predict for any individual patient, no matter what his age.
Would you say that from psychiatric side effects, which are reported to occur in I think between 10 and 30% of patients getting L-Dopa, that this was a serious complication? Certainly the most commonly quoted ones are the depression, agitation, restlessness, confusion. Some people have mentioned delirium.
Yes, we had one patient with actual delirium, as a matter of fact. Again, we found that this was most troublesome in the older age group. In the younger age group, we would get a bit of a tip-off there because they would begin to have nightmares. And we knew at this point that it was time to reduce the dosage a little bit. And we could avoid many of the psychiatric complications that way.
I think, too, that it's been observed that a great number of the psychiatric side effects actually are due to pre-existing psychological disturbance in the patient. And possibly if these were combed out a little earlier or looked for, then maybe they could be avoided. Certainly, suicide has been reported in a number of patients on L-Dopa, but to my knowledge, there are only 5 patients to date who have suicided out of approximately 8,000 Parkinsonian patients who have been treated with L-DOPA, which really is about the incidence of suicide in the general population for this age group.
I think you're talking about the same sort of problem we ran into in treating these people before the days of L-DOPA. And I think the second thing, that is the tendency to over-treat and to go too fast. I think it's very important, at least my personal impression in any case, is that this is a marvelous drug and represents a tremendous advance. And I don't think we should throw the baby out with the bathwater because it has some side effects. I think we just have to train ourselves to be more patient, to go more slowly, and let the patient live with 1.5 or 2 grams a day for a while, even 2 or 3 months, without changing the dose, to see how he gets along with it. After all, what is the hurry? Rome wasn't built in a day. Isn't it better to give him something that he can benefit from without having side effects rather than pushing it too fast, too far?
What percentage of patients responded to it, approximately, would you say?
I use 1/3, 1/3, 1/3 as an easy group of figures. 1/3 do remarkably well. 1/3 have a significant improvement, and 1/3 have problems. They either don't benefit or they can't tolerate it for one reason or another. This is roughly the same thing we found with the other drugs. We did a study of Artane, for example. We found that 25% or a quarter of the patients didn't benefit at all. Nobody knows why yet.
I think this is a fair division. And there is an advantage, though, to L-DOPA therapy that even the middle 1/3 that don't benefit as greatly as the top 1/3 usually do benefit enough that their lives are completely changed around. And, they're much happier.
Yeah.
Well, of course, this brings us to an interesting aspect of treatment, and that is there are the people who do not respond, but then what about the people who do respond? The Parkinson patient who has been sitting in the corner for a long time, maybe many years, and is given L-DOPA and he responds. Now, what about the effects on the patient and on his family? I think maybe general practitioners might be very interested in these two aspects.
Yeah. Yes, I think we've all seen this.
Yeah.
You get this relationship between the husband and the wife has the Parkinson's disease, and he's learned to look after her. Now, you're a psychiatrist, Joe, and I'm sure you're just aching to tell me what this is all about. But once they start to get better, that relationship changes, doesn't it?
Absolutely, yeah.
And then the man who doesn't have the Parkinson's disease no longer has a wife who's quite as dependent on him as she was before.
Yes, and this can be often very traumatic. From the
How should we handle it, though? Sorry, Joe, but this is an important point. How would you advise the practicing physician to anticipate and deal with this problem?
Yes, I think that one has to look at the problem in a holistic fashion. First of all, there is the patient to be improved and got better. And at the same time, one has got to tell his family that this is no longer the person that was in the family for many years, that there's going to be a change, that there's going to be a physical and an emotional adjustment in both. If the person is of average intelligence and reasonably well adjusted, I don't think that you need much more than that. But if in fact there are difficulties, or if there have been emotional turmoil in the family, then it might require a psychiatric intervention. And this might take the form of, certainly I would suggest that both visit the psychiatrist for explanation of what the difficulties would be between the interpersonal interaction in the household.
You very often have to treat the whole family and not just the individual patient, eh?
Yes, and I believe that Jerry Murphy was mentioning that there may be even a place for group therapy for the...
Yes, because certainly the family relationship prior to the use of the drug has been very rigid and very set. It's probably important to distinguish between neurological benefit and benefit to the patient in a social way. Perhaps there are rather dramatic improvements in the neurological status of the patient without necessarily any great improvement in the way that he relates with his family, because the family situation is now set. And in fact, he has institutionalized approach to life albeit his institution was really the bedroom within his home. In this regard, the non-affected spouse requires some instruction, and perhaps the Parkinsonian patient himself requires some instruction in order that they now accept more normal roles.
I think, in fact, that it may go beyond instruction, and very often the spouse will require quite a bit of support until this transition period. And here is where I firmly believe in the benefits of the general practitioner to the family. He knows the family and could probably spot areas of friction even before they arise, and give the spouse the kind of support that they need.
See this in other diseases, of course. It's not just Parkinson's disease.
No.
I mean, this is true of the rheumatoid arthritis patient. You've seen this many times, Jerry. The crippled patient at home, and somebody has to change their whole way of life to take care of them. But in those diseases, of course, the relationship may persist because the specific treatment has been lacking. But here it's, as you say, Joel, when that relationship changes, we've all seen this. You know?
There has been this question of L-dopa being an aphrodisiac, and this has been some of my own patients were wondering if, in fact, it would benefit them in this aspect. What percentage of patients do you see that they become a little bit more active sexually, or what would you say?
I'd say a very high percentage of them, but I don't believe it's due to the aphrodisiac qualities, if any, of the drug. I think they just stop being depressed and rigid and slow, and will certainly chase after what they've been missing for many years.
So then the aphrodisiac properties are not really outstanding.
No.
If present at all.
I agree with that, but I'm not sure that's the whole explanation. There's been a study done in Finland of this problem. They found about 1/4 of patients showed increased sexual interest in activity. And they raised the question whether it doesn't have a little more action. There are catecholamines in the hypothalamus, and there is a long feedback circuit to the hypothalamus on, for example, the release of gonadotropins. And there are cases reported of women who hadn't menstruated when they had the disease who began to menstruate again. And I think this is an area where it's probably there are probably a number of factors that I think are just beginning to realize. But it's certainly a very real factor, isn't it?
Oh, yes. I think one of the factors that may involve this, again, probably because of the hypothalamic action of the drug, is the development of a type of fearlessness that some of these patients get. And they go walking off across the street against the traffic as though nothing was wrong, or going out and playing 7 or 8 sets of tennis as soon as they loosen up, even though they haven't been playing tennis for 10 years. I would agree that there's probably a hypothalamic effect there that we don't know about yet, or don't completely understand.
Do you think this results from the rather large doses of L-dopa that we're giving? I think theoretically one can say that there probably is a very specific anti-Parkinsonian effect of dopamine derived from L-dopa. And perhaps some of the other effects we're seeing are a result of the presence of unusually large amounts of dopamine in areas where it wouldn't normally accumulate. And dopa and dopamine metabolites themselves may be influencing other pathways. After all, physiologically, the amount of dopamine being delivered to the receptors is under very rigorous feedback control. In having to supply this dopamine to rather particular areas, we are now having to supply dopamine to many areas of brain where it would not normally be present. And perhaps some of the side effects, in fact, it's been said some of the hyperkinetic effects are due to the large doses, and in fact these were not seen when small doses intravenously were given, and when small doses, relatively small doses, already were given.
I think that's a very important point. It's like treating a paronychia with penicillin. you have to give great hundreds of thousands of units to have it circulating in every capillary of the body in order to treat one little area of 1 square centimeter in size. And it's very much like that with L-DOPA as far as replenishing the basal ganglia are concerned. But the result is that you have to bathe the brain and the rest of the body in this substance in order to get at your target organ. That's what you're saying, Jerry, isn't it?
Well, I think the analogy is a good one. Bathing, I was thinking it's the man that requires water because he's thirsty, and we have to throw him into the swimming pool in order to get it.
Yeah.
So these dyskinetic movements that have been reported with L-DOPA, would involuntary movements which the patient might think would be either a relapse or worsening of his condition, how often do these occur, and how does one treat them?
I think they occur in about 25 to 33% of patients. They're treated very easily, usually by lowering the dosage of the drug, but the problem arises that the involuntary movements may not disappear until the patient once again becomes fairly rigid due to too low a dose.
What are the common involuntary movements that a general practitioner treating his patient should look for?
Usually mouthing movements come first, a kind of sucking, licking movement involving the lips and the tongue. And they come at a fairly rhythmical, regular interval. Later, they may develop head movements or arm movements, and finally trunk movements, usually also rhythmical, regular, gentle type of movement. Sometimes, though, it can be a flinging movement of the limb. One movement disorder is actually a lack of movement. They will have periods of freezing very suddenly, and they stay frozen for up to 60 minutes sometimes. These will come on fairly suddenly, and it's difficult to treat them. I think once the mouthing movements appear, though, it's a sign to stop increasing the drug and to lower the dosage slightly.
If I have to instruct my families to be on the lookout for these, what are the more common ones that I should look for other than the ones that you have mentioned now?
Well, I feel the mouthing movements are probably the most common ones to look for. And then gentle movements of the limbs, secondly, and finally, movements of the body.
Has anyone used paradoxin to treat these movements at all?
Not that I
David?
know.
No, talking to other people, I haven't, but talking to other people, the usual approach is to reduce the dosage. I think pyridoxine, 10 to 25 milligrams is the usual sort of dose that's recommended by injection. I think probably it will only be required in a very severe type of dyskinesia that results from the treatment. Arthur, would you agree with that in general, most people have only had to reduce the dosage?
Yes, I think pyridoxine, in fact, is a rather drastic way of treating it, since it does have antagonistic qualities towards L-DOPA.
Well, I'd just like to point out that in psychiatry, patients who've been on long-term neuroleptic drugs, especially with phenothiazines, sometimes develop these kind of dyskinetic movements. And when we stop the medication, they continue. And I think what we agree with here is that certainly if these movements are produced by L-DOPA, they can be controlled by just reducing the L-DOPA, and they're not permanent. Like I'm sure many general practitioners have seen permanent dyskinesias in patients who are on long-term therapy with phenothiazines, for instance. So I think that's a good reassuring point there.
Yes, I think that's important. I like to think that there are two main types of side effects of the therapy, and one is the initial nausea and vomiting problem, which we all go through, which is the product of just beginning treatment. But that if you reach the stage where you're getting involuntary movements, you've probably gone a little too far in your treatment. You're at the upper level, and you should pull back a little. And when you do get them, it's a sign of this. But as you say, it's remediable because they usually go away. Phenothiazines don't, in themselves, of course, don't often cause permanent disorders, do they?
No.
You get these akathisias. I've seen a couple of patients with these permanent effects in phenothiazines, but in general, they go away too if they haven't had them for too long, don't they?
Well, It's very difficult to remove them. Certainly, they have been trying to remove them with paradoxin without effect, and they have taken these patients off the drug for long periods. Often, the involuntary movements remain. Would you say that with L-DOPA, would this remove the surgical intervention in these patients? Would surgery be a treatment that should be considered for Parkinson's disease nowadays?
No. Irving Cooper himself, one of the main pioneers of thalamotomy for Parkinson's disease, in 1969 said outright at the Laurentian Conference on L-DOPA therapy that the indications for thalamotomy have now disappeared.
In those patients that received surgery, whether it was either an early or a late surgical treatment failure, would these people be candidates now to start L-DOPA?
Yes,
Definitely.
definitely.
In returning to the use of pyridoxal phosphate, commonly known as vitamin B6, a lot of geriatric patients and older patients are taking, either known to the doctor or not known to the doctor, multiple vitamin preparations. I would think that this type of concomitant treatment should be stopped.
Definitely. There are vitamin preparations available, actually children's vitamins, with no vitamin B6 in them, which can be used if necessary. But I think as long as the patient is enjoying good health and has a good diet, that vitamin should be stopped.
Also, elderly patients are frequently hypertensive. They may be receiving reserpine. Certainly, reserpine and L-DOPA would be fighting one against the other, and reserpine type hypotensive agents should not be used in these patients.
Yes,
And in particular, I think because of the very similar nature of the names, alpha-methyl-DOPA, not to be confused with L-DOPA, should not be used because, in fact, there are theoretical and well-established instances where the concomitant use of L-DOPA and alpha-methyl-DOPA fight one against the other. Would you agree with that?
Yes, definitely.
I think
What
that's a very
other
good
drugs should not be given? Anticholinergic?
No, we use anticholinergic drugs quite often, in fact, in conjunction with L-DOPA, especially for those who are bothered greatly by tremor. I think the phenothiazines in general, besides reserpine, should be avoided. The antidepressant drugs, which can be troublesome, haven't really affected our patients, and so we have been able to keep some of our patients on antidepressant drugs. But we're finding that DOPA is a fairly good antidepressant in itself, and we can avoid using antidepressants much of the time.
Would you think that monoamine oxidase inhibitors should be avoided?
At all costs.
Yes. Good.
So here is a very clear case of
Contraindication. Yeah.
namely antidepressants that fall into the monoamine oxidase inhibitory type of drug, Parnate, Marsolid, Marplan.
All those, yes, I would agree. Gentlemen, what about a look into the future? What do we see? There are 60% of patients who respond to L-DOPA. What about the other 40%? What would you say? Is there anything on the horizon?
I believe the L-DOPA decarboxylase inhibitors are going to offer us our best hope for this last 40%. This will enable us to lower the dosages of L-DOPA to very practical limits, both economically as well as physically and physiologically. At this point, I think it's safe to say we are giving more than physiological doses of L-DOPA to keep the patients going. With L-DOPA decarboxylase inhibitor, the action of this compound will prevent destruction of L-DOPA in the periphery of the body, namely the liver, kidneys probably, allowing all of it to become available to pass into the brain through the blood-brain barrier. Thus, we could probably get away with using much smaller doses, probably in the realm of 100 milligrams per day or 1 gram a day, perhaps. I think once the inhibitors are perfected, we'll see a big surge in treatment successes once again.
In this regard, it's been quoted that without the use of DOPA decarboxylase inhibitors, namely the way we're using L-DOPA now, perhaps only 10% of the administered dose is getting into the circulation.
Yes.
This means that the gastrointestinal destruction of L-DOPA is highly significant, and perhaps some biochemical tailoring of L-DOPA, whereby it gets to the right areas in the gastrointestinal tract, perhaps some minor pretreatment of patients so that the destruction within the gastrointestinal tract does not occur, would be useful too.
Of course, there's an economic factor, and it's like penicillin by mouth. You know, you deliberately give an extra amount because it's so cheap that you can allow it to go through and obtain the benefit. And I think it's going to be a question of how much these ancillary methods cost. I suspect that the price of L-DOPA, which is now very reasonable considering all the research that's gone into it, I think that price will drop further. And I don't think we've exhausted this drug by any means.
Not at all.
I'd like to thank the panel for the very interesting discussion on Parkinson's disease. And I think we all agree that although not all Parkinsonian patients will respond to L-DOPA, all patients should be given the opportunity of receiving it, since it's the most effective treatment so far discovered for this condition and can be used in combination with the other anticholinergic drugs.